Hello, everyone. We've just been waiting for a few people to join us, but I think in given time, we shall start now. My name's Georgina Moulton. I'm a Professor of Biohealth Informatics and Education, and I'm the Academic Capacity Building Lead for the BRC. And I'd really like to welcome you to the first of many training event and seminar series that we will be running on a regular basis for the BRC. I work alongside Jane. Jane, would you just like to introduce yourself before we start?
Morning, everyone. Nice to see you. I work with George on BRC education and training. So that kind of encompasses PhD students, placements, events. This is, really nice to meet everyone, and we'll get going soon.
Thanks, Jane. And today, our focus is really going to be on lupus, and particularly looking and linking that to fatigue. And we're joined by Michelle and Katie Druce, who sit within the musculoskeletal theme for the BRC. And I will do a more detailed introduction as we go through the agenda. Jane, have you got the agenda?
No, if you just want to share your slides, that'd be great.
Okay, that's great. I hope everyone can see that. It should now be in presentation mode. Okay.
Yeah, that's great. We just want to make it full screen. Oh yeah, that's great. Thanks, George.
Okay, so this outline to today's session is that we'll give a brief update of the training strategy, and then Jane will give you an overview of the aims and objectives of the training event series that this is part of. And then Michelle and Katie will do a research talk around SLE, and then we'll have some questions and next steps. So first of all, training capacity building. The BRC is been refunded from December 2022 to December 2027. And we have 13 themes in total. So this has grown substantially since we were last funded. And these are based in 4 clusters, and you can see this on the left-hand side of this slide. We have 4 clusters: high burden under research conditions, inflammation, disease complexity and multimorbidity, and cancer. And within those, you can see the themes. So today's talk will sit within the inflammation cluster, and particularly within the rheumatic and musculoskeletal diseases theme. In addition, cross-cutting all themes really, but at the core of the BRC are digital infrastructure, patient and public involvement, capacity building, and a strong program management team, an operations team that helps the BRC function. Of course, we sit in this wider landscape at Manchester, not just MFT, but we sit within the ICAP programs, the Manchester Research Networks, and all the other NIHR infrastructure that we fund. So, for example, the ARC and the Patient Safety Collaboration, etc., and the NHS Trust. So that includes MFT, Christie, and the Northern Care Alliance. And with each of these groups, there are many different roles that we hope to develop. And this can be research nurses, can be allied health professionals, but it is also focusing on the future leaders and rising stars. So we have a very complex landscape of which the BRC sits in. So in terms of the training, really what we hope to achieve for the BRC in these next 5 years is to bring together a strong community of biomedical researchers, healthcare and hybrid professionals, and who really want to contribute and conduct experimental medicine. Whilst the focus often is on just researchers, we have a really strong element of our strategy to focus on those people that contribute towards research, but not necessarily are academics. I think there are two other themes that I'd like to draw out here. This is very much in partnership with that wider infrastructure, both on a local level, but also on a national level. And we are currently working with Northern BRCs to expand our reach. So it's in partnership. And particularly, we're working alongside Bella, who leads the patient and public involvement, and Lisa Miles and Sian, who run the equality, diversity, inclusion strategy. So we are all together aligning ourselves to deliver capacity building within this space. In terms of who we are as a team, in the BRC, we have a number of capacity building leads. Each one is based within one of the 13 themes of the BRC. And these are just, this is just a snapshot of them, those people that lead for each of the themes, and also what role they participate in that theme. So whether they're a key researcher or those earlier on in their research. And this is key because we wish to make sure that we are developing a talent pipeline from early career to late career. So our training capacity building strategy was developed over the last 6 months. It was submitted to NIHR in June, and we consulted with a wide range of people across that wider landscape in order to come up with 3 pillars, which we will focus on in the next 5 years. The first one is increasing capacity and capability, which is really using structured academic programs such as PhDs and fellows to develop the research, but also to bring people into research. We're looking at short-term placements for MMAPs and a few other schemes that will develop key skills or specific skills that we've highlighted across that need to be developed. So for example, data science and informatics. The central pillar is all about continued professional development. So how do you learn and get the skills you need as on the job, so to speak? So we will do a training needs assessment a year across the BRC, and we'll be responsive to those needs. An output from those assessments will be a training passport, which will be a series of workshops, but also this flexible online teach learning, which will be kind of like bite-sized chunks like the BBC. So we are developing this resource which people can access as and when they need it. And then finally, the third pillar is around careers and community building. And here, this is about bringing people together to develop new ideas, but also to develop particularly transferable skills and their next steps, skills which they will require for their next career move. And so Jane is leading on a coaching and mentoring scheme for rising stars and early career researchers, but also we're supporting that broader research initiative through team research, which is led by Ruth Norris and Charlie Stockton Powell, and in particular non-academic careers as well. And of course, like I said, this is all underpinned and working with the EDI and inclusive research strategies. So we have a detailed plan. I don't wish you to take this in, but this is the 3 pillars and how we've broken that down. And in the first 2 years, we'll be setting up the schemes and being able to develop the cohorts so that we can see in later years how we can develop the flexible learning. So what's coming up and what does this mean for others? Well, in September, October, we have a cohort of around 25 PhD students starting across the BRC, and they will have an induction and we'll have an overarching programme that will bring them together at key points within the academic year. At the same time, we are looking to get projects for PhD projects for studentships to start in 2024. So please do keep an eye out for the call for new PhD projects, and remember they're starting in September 2024. We also will start our buddying scheme. Primarily, we're going to pilot that with our PhD cohort and our core team. And like I said, Jane and Tracy Briggs are setting up a coaching programme to develop the rising stars for the BRC. In October and November, we're looking to do a flexible learning soft launch of the innovator training scheme, And this again is in partnership with Translational Manchester and the Pankhurst Institute. And these will be made available through platforms at the Manchester University. And finally, to show that breadth, we are actually developing with Leeds BRC an early career research day that will bring together those people across the northern BRCs. And we've just set a time for that, which is the November the 22nd. So that's a date for the diary. But do keep an eye out for our communications, which Jane does send out on a regular basis. Okay, Jane, over to you.
Thanks, George. So yeah, just double check, can everyone see? Can everyone see the slide okay?
No.
Nope.
No, nothing there.
Is that okay now?
Yeah.
George, does that come up? Oh yeah, brilliant. So nice to meet everyone. Thanks all for joining. I know that a lot of people are here on, they work in research or they're your public members or patients within lupus. So yeah, thanks so much for joining today and I hope you find the talks useful. We just wanted to give a brief overview of what the seminar series encompasses and what you can expect for the next year. So the series will highlight the breadth of the Biomedical Research Centre, experimental medicine research and stimulate scientific discussion across the BRC community and collaborative work across BRC clusters and areas. So it'll also, through a lens of experimental medicine research, develop insights into key core areas such as innovation, digital, patient and public involvement and engagement, team research, and how they are being applied across all BRC research areas. It'll also create a diverse community of learning, share development opportunities and foster engagement for staff, students, public and patients and wider partners. So just a quick overview. So obviously we've got the event today, which will be recorded and uploaded to the BRC event. So if you do want to rewatch, you can watch it later. It probably be uploaded in the next week. We also have a public and patient involvement and engagement event in September, which will be in Manchester, central Manchester, next to MFT Hospital. As you can see, we've got other events coming up from October this year and up until June next year. So we will keep you all in touch with the upcoming events. If you selected to be informed of upcoming training events and opportunities on your registration today, you will be notified of these opportunities, and please just get in touch with me if you do want to be added to the mailing list as well. So that's all from me. I'll hand back to George to introduce Michelle and Katie.
Thanks, Jane. So we've given a quick overview of where this sits in terms of the BRC, but it's with really great pleasure that I'm going to introduce Michelle Barrowclough and Katie Druce. Like I said, both of them sit within the musculoskeletal theme of the BRC and are research fellows within that theme. I'd just like to do a quick introduction of both. I think they've both have very interesting careers, and given that this is a training series, I think it's always nice to hear the trajectory of people. So Michelle is focused really her research on systemic lupus erythematosus, if I got that correct, as well as chronic diseases. She's trained as a psychologist, or her undergraduate degree was a psychologist, and then she thought about doing that as clinical practice, but changed her mind and then went over to the States for a while before coming back to complete a PhD at York, at Manchester. Recently, she's been over to the University of Toronto, and that's been a collaboration funded by the BRC. And that's something where she's been able to develop this focus of her work. Katie is a research fellow also, and with the psychology background. And she moved to an epidemiological department in Aberdeen to develop and do her PhD. What's really interesting for me, as with her informatics background, is her recent work that's looked at sleep disturbance and the quality of life in rheumatoid arthritis, and particularly because that was a mobile health study. So I think today their talks will be really, really interesting to hear more about that cognitive function in SLE. So Michelle, Katie, over to you.
Hi, thank you so much for that introduction. I'll just start sharing my screen. There's a bit of a delay, so apologies. Hopefully it's going to work in a minute. Try again. There we go. Can everybody see just the slide up on the screen? Perfect.
That's great. Thanks, Michelle.
So so thank you so much for that lovely introduction and for the invite for us to talk today. Between myself and Dr. Druce, we're going to hopefully go through this topic of exploring the fog. Apologies. So what we thought we would do, as George mentioned, so my background's more around cognitive function. So that's thinking problems with memory, concentration, attention, and those problems that can sometimes occur in systemic lupus erythematosus, which I'll refer to as SLE for the rest of the talk. So I'm going to talk more about that and then briefly how it links with fatigue. Then I'm going to pass on to my colleague Katie, who has much more knowledge about fatigue, and she'll talk a little bit about that in other musculoskeletal conditions. And then we're going to give a plug at the end for a new group that we're setting up. Oops. I have no idea. Sorry. So cognitive function in lupus. So I'll give you a bit of a background about cognitive impairment, or CI, in lupus, what we've been doing with the BRC, and then, as I said, some links between cognitive function and fatigue. So I'm not sure who's fully on the call, so just a little bit of background about lupus itself. So it's a complex autoimmune disease. It mainly affects females, and unfortunately there's no cure for this condition. And over the patient's lifetime, they'll have flare-ups and remissions. It's caused by autoantibodies that can cause inflammation in multiple systems, as you can see down here on the right. And one of those systems that can be involved is the brain. And when this happens, sometimes patients are diagnosed with something that's known as neuropsychiatric lupus. So the term neuropsychiatric lupus was actually created by the American College of Rheumatology, and it encompasses 19 different syndromes. It can affect up to 80% of lupus patients. Excuse me, and of these 19 syndromes, they tend to be split into either focal or diffuse. The diffuse syndromes tend to have more uncertainty around the causes, often less serious, and by that I don't mean that it's not important, but more that it's probably not immediately life-threatening. They're more prevalent, harder to treat, and the problem is that they significantly impact on quality of life. And it tends to be the diffuse syndromes that are the most common, as you can see down here. So headache, mood disorder, and cognitive impairment tend to be the most common ones. So when we think about cognitive dysfunction in lupus, it's a major reported problem by patients in the clinic. It can sometimes be thought of or reported as this idea of brain fog. The prevalence is between 14 and 90% in the literature. This wide variance is probably due to different cohorts being measured, as well as the lack of a consistent measure. Currently, there is limited treatment options available for this, and this is largely due to the uncertainty around the cause. So on the right, the diagram gives you some ideas of some of the potential reasons why someone may suffer from cognitive dysfunction. So disease activity, so a flare-up in disease, depression, medication side effects, fatigue, which we're going to talk about a bit more later, pain, brain abnormalities, and then the inflammation and autoantibody damage that can be done. So from looking at this, you can see that some of those factors are common across other chronic disease, chronic conditions, but then there's some that are specific to lupus itself. And some research has shown that the prevalence of cognitive dysfunction in lupus is greater than in other chronic diseases such as rheumatoid arthritis, suggesting there is something specific to lupus itself, and it's not just having a chronic disease. there are other factors that are causing this problem. So if we want to talk about what we've been doing as part of Manchester BRC study and what we've learned so far, so I've been very lucky to be studying this now for the last 10 years. And most of that time I was based at the University of Manchester. But then I've also recently had 18 months where we did a collaborative research project where I was over in Toronto. And now I'm back in the University of Manchester. We're still collaborating with Toronto, thankfully, but we have quite a few other institutes that we're also collaborating with, some in Manchester and some further afield as well. So I'm going to for this next bit, I'm going to go through a few of the studies and results that we've had so far. And this is all largely due to the support from the Manchester BRC. This was one of the first studies that I was involved in. It was actually part of my PhD. And what we did here was we actually did some brain scanning of lupus patients to look at what's going on in their brain whilst they're doing sort of cognitive tasks. And what the results that are put up here are specifically in a region called the default mode network. So this region is normally involved more in self-reflective processes, and you wouldn't normally see a response during cognitive testing, which we were doing in the scanner. And what we see here is actually, what we're seeing actually is that the lupus patients were unable to reduce their response as much as the healthy controls. And then this was replicated again, similarly, when we compared those that are having a flare in their disease activities to those who are more stable. So the stable lupus patients look more like the healthy controls. But overall, lupus were unable to attenuate this area as well as the healthy controls. And then we had a look at looking whether there were any correlations between some of these signals in the brain compared to factors involved in lupus. And we found that some of them correlated with higher levels of inflammation, more cognitive fatigue, and higher scores on depression scales. So we then took this a little bit further, and we had also done some brain scans while participants were at rest. So they were in the scanner again, and they weren't doing anything. We're just looking at how their brain is while they're just doing absolutely nothing and hopefully not thinking about anything too complicated. And what we did here was, so it's called resting state, and we looked at functional connectivity within the brain. And we specifically looked at the default mode network because we saw the results from the previous work. And essentially we found that there was less connectivity for the lupus patients compared to the healthy controls. We also, because we've seen those correlations previously looking at inflammation and depression and cognitive fatigue, we wanted to see if any of those correlated with what we saw from the resting state data. We found that the depression score did, so we entered this into a mediation model to see how much was that affecting the change in the functional connectivity. And we found that it did account for 22% of our model, but that 78% was more associated with the state of lupus itself. So what this sort of basically means, so from those studies, what we sort of found was basically that lupus patients can often perform fairly similarly on cognitive tasks to healthy controls. However, we saw differences in their brain functions. So it could be that they're employing compensatory brain mechanisms to try and maintain this same level of performance. We also saw that comorbidities can affect this, but that it's not the full story. So we saw that depression had an impact, but that lupus itself had a greater impact in our model. So that was one study that I did quite a while ago, and then this is some more recent work that we've been doing with Toronto. So whilst I was over there, I was involved in a qualitative project, and I think this is really important because this qualitative project was about asking lupus patients what they think about cognitive impairment in lupus and how they feel it's affecting them and what they feel they can do about it. And I think that's most important that we understand it from the patient's perspective, because we need to know what the problem is. So from this qualitative analysis, we discovered there were 5 main themes that came from it. The first was the lupus patients, the way that they defined the cognitive impairment. So we often split cognition and problems with it into different domains, and the main domain that lupus patients complained about was problems with memory, and then followed closely by concentration and attention. And then the 4 remaining themes that came from this work were perceived cause of cognitive impairment, how this impacted on their daily life, and what sort of adaptations they put in place themselves, and then how these adaptations affect their daily life. So we can see from the perceived causes of cognitive impairment that the patients spoke to us about, they felt it could be from problems with depression or anxiety. A few, but not very many, mentioned that they felt it was linked directly to their disease activity. There was semantic symptoms, brain fog, environmental stimulation, the effects of the side effects of medication, and then that general feeling of being mentally overwhelmed. So these causes of cognitive impairment, how it impacted on their lives was that they found that they had a reduced social engagement. Their work life was much more disrupted. They had a greater impact on their health burden. They required more support from family and friends, and they were not able to take part in their leisure activities as much as they'd like. And then when we look at what adaptations that they mentioned that they put in place, there was a lot, obviously, on psychosocial support, so a lot of help from family and friends. Different memory strategies were mentioned. That was probably the most common. So just simple things like making notes, calendar reminders, things set in your phone. I think only one person out of the people we spoke to had had any medical or therapeutic intervention, so either medication or some form of CBT, I think, was mentioned. And then one of the other very important aspects that was mentioned was the energy conservation. So this idea of pacing yourself and prioritizing what kind of activities you need to be doing in a day. And then, having put these adaptations in place, the patients had reported that it improved their relationships, their quality of life, their independence, and self-efficacy. So I think what we can conclude from this is that we really need to think, when we're thinking about trying to hopefully in the future treat cognitive impairment, you probably need to look at the whole big picture. For those patients that have less family or friend support, this needs to be taken into consideration, and you probably need to think of a more multidisciplinary approach when trying to treat cognitive impairment in lupus. So one of the other problems that we've been looking at, I mentioned previously that there's a wide range of people who are diagnosed with cognitive impairment, and this is largely due to a lack of consistent measure of cognitive impairment. So the gold standard at the moment is the ACR, American College of Rheumatology Neuropsychological Battery. So this is a battery, it covers, I think, 6 cognitive domains, and there are about 19 different tests on it. It takes about an hour plus to administer, needs to be administered by a trained professional as well as graded by a trained professional. So there's a lot of impact there, and it would be difficult to use in a clinical environment. So an alternative idea would be to use a screening measure, which would be much more useful in a clinical environment. And the MOCA is one that's often talked about in the literature as a useful measure. So there's been 2 papers that have come out recently reviewing this, one of which I'm co-author on, so I'm probably slightly biased. One paper is very pro using this measure. And then the paper I'm co-author on is probably more cautious. The MOCA was originally designed to look for mild cognitive impairment, which is very different to the kind of cognitive impairment that's seen in lupus. So I think it could be a very useful tool, but possibly needs some adaptations yet. Then another way to measure it is using computerized tasks. There are multiple ones out there at the moment. 2 of the more commonly used are the ANAM, which is more used in North America, and the CANTAB that's probably used more in Europe. And these are very good tasks because they can be done on the computer. Hopefully now, I know the CANTAB now can be done remotely, and I believe the ANAM is also about to be more available online. And it can be administered by anyone. and the scoring is done automatically. So it's a good way of doing it, but we probably need to validate these more amongst a lupus cohort. And then I just wanted to mention about the differences between having an in-person cognitive assessment compared to a virtual assessment. So we recently published a paper because we'd had to do this due to COVID. The study had started pre-COVID, and so we were doing in-person assessments using the ACR neuropsychological battery, and then we had to move to online to ensure patient safety. And we wanted to see if there were differences in the performance of the participants due to the administration type. And what we did find is that there was I think it's about 42% of the tests were somehow affected by this administration method. So I think it's more likely that studies and assessments and everything is not going to go away, that we're doing this virtual assessment. So we need to look to either adapt these tests so that they can be more comparatable, or we need to just make sure that we bear that in mind when we're doing studies. We either use one or the other, or we account for this during the analysis stage. And then finally, the subjective measures. So this can be another reason why we see differences in reported levels of cognitive impairment. So by subjective measures, I mean patient-reported outcomes, and when self-reported by the patient. And this is really important because if the patient feels they have a problem, then this needs to be addressed. However, we often see this disconnect between the self-reported and then the objective measures that we use to measure cognitive impairment. So we need to understand why there is this disconnect and better understand what's going on there. So some more of the work that we've been trying to do to try and understand cognitive impairment more is using different phenotyping. So obviously lupus is phenotyped based on clinical aspects and different clinical symptoms, but then other things that are more useful when we're thinking about cognitive impairment. Many studies often compare neuropsychiatric lupus to those people who don't have neuropsychiatric lupus. And generally, we do see that those with neuropsychiatric lupus have greater levels of cognitive impairment compared to those without. But we still see higher levels of cognitive impairment in those with non-neuropsychiatric lupus compared to healthy controls. Then there's been work by Pazetsky's group. They came up with an idea of type 1 versus type 2. So type 1, they would say was more classic signs and symptoms of inflammation, so that idea of disease activity, and type 2 symptoms, sort of fatigue, depression and cognitive impairment or disturbance, which might not always be directly attributed to active disease activity as marked out by inflammatory markers and things like that. So I like this idea, but I think it perhaps splits it. It perhaps needs to be taken a bit further. And so some of the work that we did in Toronto under Dr. Toomer's team was to use machine learning to try and phenotype. And so what we did here was that we, so part of his team are collecting longitudinal data on cognitive impairment in lupus. So they've been collecting data and assessing patients at time point 0, then 6 months, 12 months, 24, and 36 months after. But this work is just on the initial visit, so at 0 months. And what we did was we collected an awful lot of data, and then we grouped it into data sets. So, and then we had 7 networks based on this. So the first data set had baseline features. So this would be demographic information and lifestyle information. Then we had clinical blood work and medication as a network, disease burden, so any damage, disease activity, anxiety and depression levels. We had health-related quality of life, PDQ-20, which is a subjective measure of cognitive impairment, and then the ACR, neuropsychological battery, which is the objective measure of cognitive impairment. So these 7 networks were then fused using similarity network fusion. Don't ask me too much about that. I had a very clever biostatistician who helped with this. And then, so they were fused together and it generated 2 subtypes. It's coincidence that there's the same number in both subtypes. So to give you a bit more information about these phenotypes that we found, subtype A had greater levels of objective and subjective cognitive dysfunction. They had greater disease damage, more fatigue, higher scores on depression and anxiety scales. They reported poorer quality of life, were more likely to have fibromyalgia. They had damage in cardiovascular, musculoskeletal and gonadal systems. And then they had system involvement, primarily in the MSK, skin and the central nervous system. So basically what we saw was that subtype A had more impairment, more damage and more dysfunction compared to subtype B. And hopefully by understanding and having these different phenotypes, we can therefore look at cognitive function differently, and we can think more about what treatments might be appropriate for the groups involved. One of the other pieces of work that we've done in Toronto was looking at changes in subjective, so self-reported cognitive impairment over time. So we wanted to see what the trajectory was. Do people always complain of cognitive impairment? Does it get worse? Does it get better? And what we found from this piece of work, again done by a very clever statistician, but I'll give you the highlights, was unfortunately that patients tend to report more cognitive impairment as time goes on. So trying to think, therefore, what can we do? How can we improve cognitive function in lupus? And I would say that it's not going to be a drug that solves this on its own. It might be alongside something, but I would say it's probably going to be a multidisciplinary approach with different factors involved. But when we're thinking about possible pharmaceutical treatment options, again, some work by Dr. Toomer's team in Toronto, they've looked at some of the immunosuppressants because we've seen that microglial activation within the brain is linked to cognitive impairment in lupus. And so we know that some of the immunosuppressants can reduce pro-inflammatory microglial activation. So there has been 2 studies so far done on this. One you looked at azathioprine and MMF. And that actually found that there's a potential for azathioprine to have a protective effect on cognitive impairment in lupus, but more work is needed. The second paper looked at ACE inhibitors and ARBs, and unfortunately there was no association found with cognitive impairment in this paper. But I think it was a paper that I was co-author on, and I think we needed to really think about the fact that it was a retrospectively designed study, and there was quite a lot of selection bias involved in that. And so really more work needs to be done. And thankfully, there is a randomized control trial happening in New York, I believe, looking at the effects of these medications and if they can help with cognitive impairment in lupus. So to sort of summarize what we know so far about cognitive impairment in lupus, we know that there are potentially multiple causes, and trying to understand it is complicated by the fact we don't have a consistent measure at the moment or a consistent definition. Hopefully we can get some help from different phenotyping, some of the potential neuroimaging markers, and then agree a cognitive impairment measure. And then this might help lead to the development of a future clinical trial where we can treat cognitive impairment in lupus. So this is where I'm trying to link more to the cognitive function side of it. So what remains unclear, cognitive fatigue side of it, sorry, what remains unclear so far? So we're still trying to measure cognitive impairment in lupus, and what does it mean to those people who have lupus, and this disconnect that we have between the subjective and the objective. So we need to look at that a little bit more. I've mentioned that we need to have a uniform measure of cognitive impairment. We need to understand what the long-term implications. Does it mean that everybody is going to get worse, or can people improve and get better? And then does the phenotyping help? So I keep mentioning about this disconnect between subjective and objective cognitive impairment, and it's trying to understand what exactly is subjective cognitive impairment. Is it this idea of brain fog that patients report, or this feeling of cognitive fatigue? And could it be that patients are reporting problems, but because their brains are compensating, they don't have objective cognitive impairment when we measure them? And could there be, we don't fully understand the relationships between all these aspects, and we need to understand this a little bit more. And so could it be that this idea of cognitive fatigue or brain fog is a precursor to objective cognitive impairment, and at what point might these mechanisms fail? And these are things that we still don't know. And it's why I've started to have this greater interest. Well, I've always been interested, but suddenly really need to look more into cognitive fatigue and fatigue in general. So I'm almost finished, and I'm almost going to pass on to Katie. So fatigue in lupus, so not just this idea of cognitive fatigue, but fatigue in general is reported in up to 90% of patients, and it's got limited treatment options available. There's poor health-related quality of life, and as I mentioned, there's multiple different types of fatigue, and I'm just starting to try and understand the aspect of cognitive fatigue, but there's many more that are involved, and it's common across other MSK conditions. And so I think that's where we need to go next. And that's why I am hoping to start to work much more with Dr. Katie Truce, who knows much more about fatigue in musculoskeletal conditions. So I'm going to hand over to her now.
Can I mention the chart? That's okay. Yeah, so I'm Debbie McGee to Michelle's Paul Daniels, and I'm literally, unlike Debbie McGee, here to just be disruptive. So Michelle and I, for a number of years, have found ourselves in rooms basically saying the same thing, but talking about different things. So she's been in the room talking about cognitive impairment, and I've been in the room talking about fatigue. And then you have that moment where you look at each other and you say, we're saying the same thing. We're saying that patients are talking about the same thing. And the other difference is I'm much more rheumatoid arthritis focused to Michelle's lupus focus. And we're going, well, hang on a minute. These symptoms are really similar, but also in other conditions, they're really similar. And so that's really started us having some really interesting conversations about whether or not we are approaching the same thing differently, and what the potential kind of benefits and potential problems of that might be. So I'm going to just do a bit more about kind of fatigue generally. It's quite a light touch for this because it's really to springboard more of a discussion point for the fatigue group that we're hoping to set up. So I don't have that many details. It's more just discussion. So by fatigue, what we mean, and the definition that we commonly use, is this subjective experience of a really intense tiredness or exhaustion. And I think lots of people feel like they know what that means, but where fatigue is really different from normal tiredness is it's often really unrelated to the amount of energy you've expended, and it's not relieved by rest. So having a lie down doesn't necessarily get rid of this sensation of fatigue. And people talk about it being unfair, unearned, and unpredictable. And the really interesting thing is it's common across almost every rheumatic disease and most chronic diseases in general, actually. And it's somewhere between 4 and 8 times more prevalent in a rheumatic disease than in the general population. So it's a really massive issue for patients. But it's not just an issue for patients. Actually, if we look at a societal level, so sure, fatigue is a key determinant of health and well-being. It's a barrier to relationships, and for the individual, that's huge. But for society, it costs somewhere between 13 and 26 billion pounds per year when you include things like medication costs, loss of employment, sort of damage to the economy. So it's huge. And it's a key reason for somewhere around 30 million lost working days in 2016. So, it's got a massive potential to impact on the individual and society at large. And I think one of the really interesting things is it's sort of really ubiquitous. It doesn't matter if it's an inflammatory disease, if it's a non-inflammatory disease. It doesn't even matter if your inflammatory disease is in remission and you're getting the best available treatment that you can have. You could still have fatigue, and it could still be a level of fatigue which is sort of unacceptable or unreasonable for you to live the life that you want to. So fatigue is sort of commonly reported amongst different conditions. So I think there's 2 points here. One is that it's, if you ask a patient how to describe fatigue and you didn't know their diagnosis, you wouldn't necessarily be able to say, oh, that's an RA patient or that's a lupus patient. But if you think about some of the phrases that Michelle has used and some of the diagrams Michelle has used, hopefully by the end of this section, you'll see that actually the research suggests it's quite similar. The same things come up as being associated with it. Similar descriptors, similar measures are used. So it's something that is really much more similar across conditions than it is distinct. The only caveat to that is that in chronic fatigue syndrome or ME, there's a really dominant feature of fatigue that's post-exertional malaise, and that's specifically fatigue that happens after there is a level of energy expenditure. That's not commonly seen in other conditions. But if you take that feature out, actually, even amongst CFS ME patients, the descriptors tend to be the same. And so for everyone with a chronic condition, fatigue is important. For everyone with a chronic condition, fatigue can be similarly experienced and similarly described. For everyone with a chronic condition, it's really badly managed. And yet what we tend to do as researchers is we tend to go, but I research RA, but I research lupus, but I research fibromyalgia. And actually, there's a potential that that's just damaging our ability to progress forward with our understanding of these symptoms. So I sort of touched a wee bit on the management there, and this is really similar to what Michelle's spoken about, particularly around the cognitive function. So there's basically nothing. So the recommendations for how to manage fatigue might include talk to patients about their fatigue. Typically, we know from the clinicians we speak to that involves, are you experiencing much fatigue? I am, yeah. Okay. I'm really sorry to hear that, and move on, because I can't do anything about fatigue. And actually, we've had clinicians say to us, I tend not to ask about it because I know I can't do anything. So what I'd rather ask you about is your pain, because I know that I can do something about that. Or I'll ask you about your joints being swollen because I know that I can do something about that. It might be that people recommend you do a medication review. So is that person being given treatments which are known to cause fatigue as a side effect? Could you swap it for something else? And then also encourage self-management strategies. So that would involve things like energy expenditure and pacing, exercise, which people sort of struggle with because it feels really counterintuitive. Sleep, which is also bizarrely counterintuitive because sometimes sleeping doesn't help fatigue get better. So it's a bit of a kind of a chicken and egg sort of situation. What's making it worse? What's making it better? And then diet. And diet is one of the things I think when you present to particularly patient groups or audiences where there's a lot of patients, everyone has a story about how diet has helped them. And there's no denying that that's a really common belief. But the data on diet is really, really poor. So the suggestion is, if you find something that works for you, crack on, but actually there's no sort of recommendations that we can make. And it's kind of like, well, is that it? Is that all we've got available to us? And just to flag up that this is the management taken from the Rheumatoid Arthritis Society Fatigue Matters book, and that was I was working with them on that, and it was kind of like trying to do a top range appraisal of what the information was, and actually, yeah, that really is it. So the NICE, so the National Institute for Healthcare Excellence, who, you know, they inform us about what we should be doing for management of a range of different conditions and symptoms. They basically have no guidance for fatigue at all among people with rheumatic diseases, really limited guidance in other conditions. There's mention in the guidance that does exist about referring people to appropriate specialists, providing education, recommending sleep hygiene, management of pain or concurrent mental health problems. And two really crucial things is, first of all, the quality of the evidence for that is really unclear and probably poor at best. But the other thing is, you'll notice that none of those things actually focus on targeting fatigue. So sleep hygiene improves your sleep, the assumption being your fatigue will get better kind of as a consequence. Managing pain better, managing mental health better. your fatigue gets better as a consequence, but it's not actually targeted. And the reason for that is because we don't really understand fatigue. And this links back to some of Michelle's points where there was that kind of cog going on. We don't really know what's happening where and in what order. And there's a number of reasons why that is still the case. So for a number of years, it's been, recommended that fatigue is measured in all clinical trials. It's been identified as a really important symptom, but we're still not there yet. And that's because for a long time, fatigue was ignored. So it was ignored in research and it was ignored in clinical practice. And that's largely in clinical practice, like I say, because there are no options. You can't do anything. Why ask a patient about something you can't do anything about? There's also been this kind of dominant assumption for a number of years that it's just about inflammation. So inflammation causes fatigue. And if you get rid of people's inflammation, their fatigue will get better. But actually the data is really mixed, and therefore controlling inflammatory disease activity doesn't actually necessarily mean controlling fatigue. And then there's an additional issue where actually fatigue seems to cluster within diseases. So much like Michelle's phenotyping stuff around like type A and type B, there are people who have differences in the way that they experience fatigue, but those differences are among people who they all have RA, but they separate into different groups, not RA versus lupus. So you might find that actually someone who has an inflammatory driven fatigue in RA is much more similar to inflammatory driven fatigue in lupus than somebody who just has fatigue because they've got kind of mental health problems and pain. So there's this real complexity that we haven't historically picked up on in research. So just wanted to touch a wee bit on the idea that it's not just all about inflammation. So we, from my PhD and then some others, have shown that actually this assumption doesn't really help us, because when you treat people's inflammation, fatigue still persists, and that actually even when fatigue does improve, it doesn't normalize. So you're left still with this unacceptable level of fatigue. But we showed in this structural equation model that basically the pathway by which inflammation or disease management is affecting fatigue is because your disease gets better, your pain gets better, and then your fatigue gets better. So actually that link between inflammatory disease and fatigue doesn't really exist in the way that historically it's been assumed to. And the other issue that we've got is fatigue is really complex. And I think the really nice thing about that, Michelle had that diagram where all the possible causes of cognitive dysfunction were sort of around the outside. And if you look at this model, you can see a lot of them. So inflammation, pain, depression, sort of behaviors, a lot of these things are coming up time and time again. So fatigue, cognitive impairment, cognitive function, they're all really complicated, but they're all also really, really similar. So these symptoms could just be the same sort of feature. One is that it's described by patients, one is that it's measured objectively, or it could be that they share kind of similar mechanisms. But the issues are we need to capture all of those mechanisms, and we also need to think about the fact that different things affect different people, even within the same disease. I think that where we've kind of come to on this is actually, if you look at this diagram and I think the only one change you need to make is it says RA drugs kind of towards the top left. Take out RA and you just have drugs, and then and then in the green bar you get rid of rheumatoid arthritis and you just put disease. There's very little there that wouldn't be applicable to all diseases where fatigue is prevalent, and yet we have a rheumatoid arthritis specific model. We might have a lupus specific model, and it just feels like maybe it's the wrong way to go about researching these kind of symptoms. So on balance and in a whistle-stop fashion, hopefully it's sort of indicated that the causes and consequences of fatigue are probably not unique to specific diagnoses. And if they are specific, it's a very niche aspect of that symptom, which is specific to a specific diagnosis, like the post-exertional malaise would be in CFS. And we are sort of now working on the idea that actually maybe fatigue, the things that cause fatigue, and the treatment strategy is more common across long-term illnesses than it is distinct. And that actually in future, there may be benefit from looking at that and seeing whether or not we could get more power behind our studies, we could have more clout in our impact if we just start looking across different conditions. So with that in mind, and a shameless plug that is open to anyone, researchers, clinicians, patient partners, anything, Michelle and I are looking at sort of just for the time being, gauging interest in a new fatigue group. Now, this would be kind of people coming and talking to us about what they're currently doing in a fatigue, cognitive impairment kind of space, or their experience of fatigue. And at the minute, we have met with just MSK focused researchers, and we've got a little group of that, but we really want to expand it across the BRC. So if anyone's interested in what we were talking about, or maybe joining us and discussing a bit further, then our email addresses are there, and we would love to hear from you. Thank you.
Thank you very much, Michelle and Katie. That was fascinating, and thank you. Really very interesting. I'm just looking in the chat actually here with regards to some points that have been raised around a recent management plan that's going to be published, I think, for fatigue and inflammatory rheumatic diseases. Perhaps Eek Juras would like to say a little more.
Right, yeah, sorry, that's Emma. Eek is fine. Yeah, so we were funded by EULAR to develop management recommendations. So we followed, I don't know if you know EULAR, it's a European Association for of Rheumatology groups, and they have a standard operating procedure for developing management recommendations. So we did 2 underpinning systematic literature reviews of pharmacological and non-pharmacological interventions. We had a sort of multidisciplinary task force looking at fatigue. So we're about to, can you hear me, by the way?
Yes,
Okay,
yeah.
Great. We're about to publish the systematic literature reviews and also the management recommendations, and that's across inflammatory rheumatic conditions.
That's really exciting. If you can send us the links or the papers, that would be really appreciated. I'm sure they will pop up. Yes, thank you. That's really helpful.
Very happy to. Yeah. We've also just got some funding from Versus Arthritis to do a scoping review of available interventions to try and look at the theoretical underpinnings behind them, and to do some work around measurement, because I think that's come up as well, hasn't it, as one of the really big challenges, makes it really difficult. So we're going to be looking at that across the life course. So also looking at children and young people as well as adults.
Is it Emma? Sorry.
It is, yeah.
Whereabouts are you based?
Emma's in Bristol.
Oh, you're in Bristol.
I'm in Bristol, yeah.
Ah, okay. I was thinking, oh, if you're in Manchester, we could. But I don't think there's any reason why we can't expand out. It would be great if we have our Manchester group, if we sometimes have
So Michelle and I have this debate, Emma, about, she's talked about me being an expert in fatigue. Emma's the expert in fatigue. Yeah, definitely.
Well, we're very grateful for you being here at the talk then. But yes, so we're trying to obviously just set something up here in Manchester, and I suspect that Katie has read much of your work. Yes.
Likewise, I've read all Katie's work too. Yeah. There's also a group I went to a couple of weeks ago up in Newcastle. Do you know Fi? Who's also probably got some really good links.
So once we get the Manchester group up and running a bit more, then maybe we can start liaising with the other big groups around the country, I think. Yeah. Thank you so much.
Sounds
And Emma, please feel free to share these groups and all your details, where the information will be published, etc., and we can share with attendees today, plus anyone else that's interested. Does anyone else have any further questions? Feel free to ask on voice or on the chat, in the chat. No, I had a question for Michelle and Katie, if that's okay. Just, it'd be great to hear your future plans for research and your hopes and dreams for treatments in your areas, yeah, and healthcare overall in your focus areas.
Yeah, so I'm currently working on a project, a smartphone study about tracking symptoms kind of in between clinical appointments, putting the data into people's medical records and sort of seeing if clinicians have access to how you've actually been, not how you think you've been or how you can remember you've been. Does it make treatment choices better? And I think really using, I'm interested in using quite similar methodologies to get a sense of what's happening on fatigue and these kind of phenotypes and stuff, but looking at some of the work that Michelle does, where we're not just going to ask about fatigue, but try and kind of objectively measure what's going on as well. So those cognitive tests that Michelle uses, sometimes they're spoken about as cognitive impairment tests, sometimes they're fatigability tests, sometimes they're fatigue tests. So really, I think working together a bit more and trying to get a sense of that, but kind of in the real world rather than the way that